Dear friends, good afternoon, and we proceed with our plenary session. And today, we hope to provide interesting discussion at the end of the day. As we believe here, the topic of our discussion today is the concept of undetectable is equal to untransmissive. Probably for the first time in our conference, we are going to discuss these issues in Russia, as we believe this is the very important component combating HIV pandemic. And what is important here are scientific and social aspects of this concept. And we invited global experts in this area today to have this roundtable discussion. And I'm happy to give the floor to Anton. Thank you, Alexander. Yes, the concept undetectable is equal to untransmissive is very simple. That means the person who is getting effective ART does not have the risk of transmission of HIV via sexual route. And this simple concept, but sometimes we face a situation that the information which is provided by different sources is not ideally interpreted. Some people believe this concept is not properly justified. Some people believe that this is ideal and possibly it's an axiom by now. But as we see by the results of different trials, for example, the positive perspective study, that only 66% of doctors all over the world do tell the patients about the principle of unequal on. Russian figures are even lower because only 46% of doctors do inform their patients about the principle N is equal to N. Non-detectable, that means non-transmissive. Let's put the dots over the I's. Do we have any doubts among modern HCPs in this concept of non-detectable is equal to non-transmissive? And let's discuss it to those who actually were the godfathers of the concept. Alison Roger, who is the professor of infectious diseases in the Global Health Institution, University of London College, and also infectionist and director of the public health care of the Royal Hospital in London, and also Bridge Richmond, who is the godfather and founder of the company Undetectable, that means untransmissible. And also we invited leading Russian experts, Natalia Ladne, the senior researcher of Epidemiology Institution of Rospotrebnadzor, which is our regulator, and Alexander Pronin, who is the chief doctor of Moscow Regional AIDS.CENTER and chief specialist of Moscow region of HIV infection. We start this session from a very good and very interesting presentation about the scientific concepts of N equal to N. Alison Roger.
Right. Thanks for asking me to talk today about the scientific evidence supporting U equals U. So if we think about the state of the evidence, well, the science clear, data is indisputable. We know if you're on suppressive ART, the virus simply cannot be passed on. So although we've known about the impact of antiviral therapy and HIV transmission for a long time, almost 20 years now, stating that antiviral therapy stops this completely is new and it's important. So over the next 20 minutes or so, I'm going to talk through the scientific evidence supporting U equals U and just cover a couple of the big questions that come out. I know many of you will be familiar with the evidence, but I think it's really important we understand just how robust this evidence is so that we're able to go out and spread what is a very important message. So I normally start when I'm talking about HIV transmission and U equals U to remind people that even in the absence of condom use and antiretroviral therapy, the risk of HIV transmission is actually quite an uncommon event. So if you look at the right-hand side of this figure, in terms of what we would think was the sex most associated with transmission, that's receptive anal sex, even without a condom and not using ART, the risk is really about 140 per 10,000 condomless sex acts. And what we're doing with antiviral therapy is taking something that's a generally uncommon event and pushing it right down towards the left of the figure, which is no risk. So as I said in the introduction, we've really known about the impact of antiviral therapy for about 2 decades. So this was really the first study using the RACI data, which was published in 2000 in the New England Journal. And these were 415 serodifferent heterosexual couples in Uganda who were followed up for 30 months. So antiretroviral therapy was not being used. But what the researchers found, as you can see on the figure, is a very clear gradient between the HIV viral load of the positive partner and the risk of transmission to the HIV negative partner. And that was for both male to female and female to male transmission. And in the 51 couples where the positive partner didn't have a viral load above 1,500 copies, there were 0 transmissions. So in the years following that, there were a number of other cohort studies from around the world. And what the Swiss group did in 2009 was they combined the data in a meta-analysis, and they demonstrated through this forest plot of summary HIV transmission rates per 100 person years, and they separated it according to use of antiviral therapy and the plasma viral load of the positive partner. So out of the 11 cohorts, there were just about 5,000 heterosexual serodifferent couples. And what they saw in this meta-analysis was a 92% reduction in risk from 5.64 to 0.46 per 100 couple years of follow-up. But at the time, the WHO reviewed the evidence, including this meta-analysis, and they felt that there just wasn't sufficient evidence to formulate guidance on the role of antiretroviral therapy in terms of prevention, both at the level of the individual and also at the population. But luckily, we got the highest level of evidence shortly after, and this really was the landmark study in the field, the HPTN 052 trial. So what they did was they randomized almost 1,800 serodifferent heterosexual couples where the positive partner was put in antiviral therapy immediately, or they had antiviral therapy delayed until their CD4 count dropped below a certain threshold. And the primary outcome for this study was phylogenetically linked transmission events. So we know that it's really important that they were phylogenetically linked, because in all the transmission studies, you tend to see up to a third of transmissions happening from outside the partnership. So it's really important to know if the transmission had come from a positive partner on suppressive ART. So this study was supposed to run till 2015, but in 2011, the Data Safety Monitoring Board recommended that the results of the trial be announced immediately, and that everyone who was in the delayed arm was offered antiviral therapy immediately. And the reason they did this, because they saw a 96% reduction in the risk of transmission to the negative partner if the positive partner was an antiviral therapy. So this is obviously fantastic in terms of HIV prevention, but it's not quite U equals U, is it? When we're not saying it's 0, a 93% reduction. But if we look in more detail at the 8 negative partners who seroconverted when their positive partner was on treatment, and I know it's quite a complex slide, but if you can see case A to H, and if we look at the top 4 first, and I've put the main data in this red box, so look at the left-hand side of the red box. What this does is tell you the number of days that the negative partner seroconverted, that their positive partner had been in treatment. So they either seroconverted either just before, 5 days before the positive partner went to treatment, or up to 4 days afterwards. So this really shows that the negative partner in these 4 cases seroconverted shortly after the positive partner started treatment, when obviously the viral load in the positive partner was not suppressed. And then if we look at the lower 4 cases, what you can see again on the left-hand side is the number of days since the positive partner started treatment. So this is a number of years down the line, and what we can see looking at it though is that the viral load of the positive partner is not suppressed. So they were obviously failing treatment, and I think underpins that we have to support people put onto HIV treatment to be able to maintain a suppressed viral load. So looking at these 4 cases of the negative partner seroconverting when the positive partner was on treatment, we can see that the first 4, the positive partner had just gone on to treatment, the viral loads weren't suppressed. And the later 4, the partners had been on treatment for a number of years, but were failing treatment and the viral load was not suppressed. And what we can see from 052 is that there was a 100% reduction in transmission if the viral load was less than 200 copies. So U very much equals U. So you might think that was sufficient evidence, that it was a randomized controlled trial, really good results. So why did we feel that the evidence just wasn't quite there, and that as important a message as U equals U required just a little bit more evidence? So we set up the partner studies, because although we know we'd quite good evidence in heterosexual couples of the reduced risk of transmission from condomless sex with suppressive antiviral therapy, we just didn't think we had the evidence for gay men. So only 2% of the couples in 052 were MSM couples. So there was no direct evidence for anal as opposed to vaginal sex. And we also know that condom use effectively prevents HIV transmission. But in most of the transmission studies to date, there have been very, very few couple years of follow-up where partners had only used ART to prevent transmission. They'd also used condoms. And we also felt that even if you find zero transmission, that's not the same as saying there's zero chance of transmission. You have to really get the evidence, very large studies, to get the couple years of follow-up so that you get really tight estimates around your findings. So for these reasons, we set up the partner study. So the partner study was an observational multi-center European study, 72 sites of 0 different couples, so 1 positive and 1 negative, and we recruited both gay couples and heterosexual couples where the positive partner was on antiviral therapy. And the study ran in 2 phases. Partner 1, 2010 to 2014, where we recruited both gay and heterosexual couples, and then Partner 2, where we just recruited gay couples only, and follow-up for that study finished in 2018. And the aim of the partner study was really to estimate the risk of within-couple transmission during periods where condoms weren't used and the positive partner was on suppressive ART. So I just always want at this point to thank all the partner study participants who so generously participated in our research and enabled us to provide the evidence for the U equals U statement. We're enormously grateful. So I just want to talk a little bit about the study procedures, because I think it's quite important to understand just how robust the evidence is in terms of these big studies. So we only included a couple years of follow-up when HIV tests at the beginning and the end of the period if the couples had condomless sex together during the time period. The negative partner hadn't used PEP or PrEP, although we did encourage them to do so. And the HIV viral load of the positive partner was less than 200 copies. So if a negative partner seroconverted, we obtained HIV-1 pollen N sequences either through plasma or PBMCs by Sanger sequencing, and we complemented that by deep sequencing by Illumina in a subset. We got control sequences so that we could construct the phylogenetic trees to look for linkage, and the control sequences were the 10 closest sequences through searches of GenBank. We used replicate partner sequences or confirmed HIV transmission pairs. So you can see that in the phylogenetic trees that we conducted, the partner sequences in blue, the control sequences in red, and the transmission pairs in orange. And if a negative partner seroconverted, then it was classed as a linked transmission if the partner sequences clustered together in a monophyletic branch with high statistical support, and we used a bootstrap value of greater than 0.9 or a posterior probability greater than 0.95, and had a pairwise genetic distance of less than 0.015 nucleotide substitutions per pol site. And this is all published and well-recognized methodology. So I just really wanted to spend a minute or two on that, just so that you understand how robust these studies were, really looking hard for linked transmission. And this is where we were at the end of Partner 1. So we had 1,238 couple years of follow-up, a really large study. The couples had sex without condoms 58,000 times, and we got 0 transmissions. But as I said earlier, you want to be really sure of your estimates. So what we did was we looked at the confidence intervals around the estimates of 0. And for couples who had heterosexual sex, it was 0.46 per 100 couple years of follow-up, and that translates into an absolute worst-case scenario, so upper limit of 1 transmission after 217 years of condomless sex. But for gay men, because we had less couple years of follow-up, even though we got 0 transmissions, the upper limit was untransmission after almost 120 couple years of follow-up or condomless sex. So although that's obviously out with someone's lifespan, we didn't feel that gay men should have a lower level of evidence than heterosexual couples. So we kept going with the partner study. And in retrospect, I'm very pleased that we did, because when we published the results of partner one in JAMA in 2016, it was actually accompanied by quite a conservative editorial, which was titled, Condomless Sex with Virologically Suppressed HIV Positive Individuals, How Safe Is It? And in particular, this phrase where they talked about, we just don't know how safe it is. We don't know the actual numbers. More evidence is needed. So we kept going. But in the meantime, before we reported on partner two, the Opposites Attract study reported. And this was a really nice study from the Kirby Institute in Sydney by Andrew Grulich and Ben Bavington. It was a smaller study than partner, but they had 12,000, almost 13,000 condomless sex acts with no PrEP and no HIV transmissions. And then we had what we hoped was the final part of the jigsaw. Presented in 2018 at AIDS 2018 in Amsterdam, the results of the Partner 2 study. And so what you can see is by this time we had accumulated almost 1,600 eligible couple years of follow-up, and this is just in gay men, 77,000 condomless sex acts. And this was a real-world study. So a third of the negative partners, 23%, were diagnosed with an STI during follow-up. A third of them had condomless sex with other partners. And as I said above, condomless sex 77,000 times without using a condom. And despite this, although 15 of the negative partners became HIV positive, none of these were linked to their positive partner on antiretroviral therapy. And if we look at the results of the phylogenetic analysis, so 15 of the HIV positive partners had subtype B infection, and 6 of the negative partners who seroconverted had acquired non-B infection, so they were obviously not linked. But if you look in the phylogenies, none of the partner sequences clustered together, and this had consistent results across all the analysis. But by contrast, if you look at the tree, the control sequences, which were the replicate sequences in red or the confirmed transition pairs, they always clustered together with high statistical supports. Whereas in contrast, the median pairwise genetic distance for the partner sequences in blue was 0.068 and showed pairwise genetic distances greater than 0.04. So the partners, the transmissions in the negative partners did not come from their positive partner on ART. So if I can just remind you where we were after partner 1. If you remember, in gay men, the absolute worst case scenario was 1 transmission after having condomless sex for 119 years. And if you look at what we achieved with the partner 2 results, we reduced that such that you would have to have, in a worst case scenario, sex without condoms for almost 450 years to be able to have 1 transmission. So I think it was very, very clear that the risk is 0. It's possible if someone is on suppressive antiretroviral therapy to transmit. And I think if you look on this slide, where you look at how the evidence for U equals U weighs up, despite all the concerns about potential risk, there's not been a single verified case of HIV transmission in the literature in the context of completely virally suppressive ART. And by contrast, if you look at all these slides in the blue bubble, really big studies designed specifically to look for HIV transmission, and they were unable to do so. So the science is there, the data is indisputable, the virus simply cannot be passed on if a person is on suppressive ART. So I'm just going to spend the next 5 or so minutes just talking about what I call the yes buts. So I do keep talking about this because I think it's important to keep reminding yourself just how robust this evidence is, but people always have the yes, but what about this? And one of these was through Trip Grulich gave a talk called HIV, Does U equals U? Well, maybe not. And although he later admitted he was just doing one side of a pro and con session, these questions do keep coming up. So the first thing people say is yes, but what about genital shedding? So I think the important thing to remember about genital shedding is that the HIV RNA load in semen is correlated very strongly with the levels of HIV in blood. So if you're suppressed in blood, you are likely to be suppressed also in semen. And we know that you can detect intermittent shedding in semen, even if men who have a suppressed HIV viral load, but this is at really low levels. It's usually less than 2,500 copies. And this really nice study from the mid-1990s showed that at a kind of levels of about 2,500, 3,000 copies, you are simply unable to culture the virus. If you look at the box plot on the right-hand side of this figure, you're unable to culture when you're in the level of 2 to 3 logs of HIV viral load in semen. You really have to get very high levels of HIV viral load in semen to be able to culture the virus. So I think this indicates that low-level HIV RNA in semen doesn't correlate with the risk of transmission if plasma viral load is suppressed. That's either because the HIV detected in semen is either defective, not replication competent, or doesn't reach a concentration required for transmission. This also is relevant if you use 2 drug regimes such as dolutegravir and 3-TC. The shedding is also at very low levels, so the key is to be suppressed in blood. And we also know that the participants in all the transmission studies, we didn't look at seminal shedding in partner, but people would have been shedding virus and semen and there was still 0 transmission. So I think we can put that one to bed. I don't think genital shedding is of any relevance at all if you're suppressed in blood. So the next yes but that we get quite a lot is you're only as good as your last viral load. So we know U equals U is only easy to apply, where people living with HIV have access to testing, effective treatment, viral load monitoring, and the right support to reach and maintain viral suppression. But in these circumstances, the risk of viral load rebound is very low. And some UK data, the SHEIK data, looked at rate of rebound, and it was less than 1% per year in gay men on suppressive ART. And the longer they remained suppressed, the lower the likelihood of rebound, and most of the rebounds were temporary and low level. So partner was real life. We checked viral loads of the positive partner 6 months to annually. And in almost all the couple of years of follow-up, the viral load was less than 50 copies. So if you've been suppressed in the past performance predicts future, you're likely to stay suppressed. There were very few blips and very few of them went above 200 copies. So to say you're only as good as your last viral load, if you are supported to take treatment, then you're very much as good as your last viral load and you will remain suppressed in blood. So again, I don't think that this is something that should detract from the U equals U message. So another question I get asked a lot is, does U equals U apply in the first 6 months in ART once you're suppressed in blood? So if you suppress by 4 months, do you have to wait for another 2 months before you can say U equals U applied? So I think for me, the real question in early ART is just genital suppression lag behind blood viral load suppression. So this is a really nice study, if you look at the figure on the right, which looks at suppression using rilpivirine, elvitegravir, and boosted darunavir. The top part of the figure looks at suppression levels in blood, and the bottom looks in semen. So what you can see is this 2-phase viral decay, which is mirrored in blood and in semen. And you can see this rapid first initial phase of decay followed by a slower second phase out to the end of the figure at 12 weeks. So you can see in semen, both rilpivirine and elvitegravir mirror the really rapid reduction in blood, achieving undetectable viral load in semen faster than darunavir. But the key thing to note is once your plasma viral load is suppressed, your genital shedding is minimal. So I think once you're suppressed in blood, then I think your genital secretions are suppressed, shedding's minimal, and U equals U does apply once you are suppressed in blood, particularly with the newer regimes such as rilpivirine and elvitegravir. So if we look at the state of the data, so the science, as I said in the beginning, is there. I hope over the last few slides I've shown you it's really indisputable now. If you're on suppressive ART, the virus can't be passed on. But I think we need to keep talking about it so people gain a lot of confidence, because we have to think about how successful we are in getting the message out. So we know that U equals U is hugely important. I think it's one of the most important campaigns that I've seen in the history of HIV. We know it transforms the social, sexual, reproductive lives of people living with HIV. We know it dismantles HIV stigma. It encourages testing, treatment, staying in care, and it provides a very strong public health argument for eliminating all the barriers to universal access to care. But I think, unfortunately, there's evidence that a lot of people living with HIV, medical providers, and those at risk of acquiring HIV are not aware of the extent to which successful treatment prevents HIV transmission. And I think the confidence that we have in the role of antiviral therapy and saying there's 0 transmission was really demonstrated by the CDC mid last year, basically saying if you're on suppressive ART, there's 100% effectiveness, which is really quite a stunning statement and shows how confident people are now in the evidence behind U equals U. And indeed, Tony Fauci, who is the ongoing hero of the hour with COVID, he very much regards the concept of U equals U as being the foundation of ending the epidemic. So when we published the Partner 2 results in Lancet last year, we're not very good as academics at getting the message out, but we really tried hard. We worked with Bruce Richmond and the U equals U campaign to try and really show the level of evidence underpinning U equals U. And for 24, 48 hours, it really saturated the news venues, and we hope that it just in some small way managed to get the word out. So I just really want to thank you for listening, and just to reiterate the message, people on effective ART cannot pass on the virus. Thank you very much.
Thank you very much, Alison. Fantastic presentation. Actually, it covers all possible questions and shows us that science is here. Science is here, 100%. No doubts, no concerns, no fears, no stipulations. This is very robust science that proved the efficacy of this concept. And extremely interesting, it was listening to the options of suppressed viral load earlier than 6 months. So, as soon as we get the result of undetectable, we already can say that the person cannot transmit the virus to its sex partner. So this is extremely important, and we come back to you, Alison, during Q&A session. And now I'm happy to give the floor to the person who is probably godfather, and due to him, we managed to provide this concept to the public authorities. This is Bruce Richmond, who is the founder of the company Undetectable Equals
Hi, I'm Bruce
Untransmittable.
Richmond, the founding executive director of Prevention Access Campaign. And I'm very honored to be here today to share with you U equals U and talk about the message of U equals U as well as the movement to ensure that that message got out to the public. So first we're going to say, look at what is U equals U. I think most people who are watching this webinar know what U equals U is already, but just in case, U equals U means that when a person who is living with HIV is on treatment and has an undetectable viral load, which we are considering under 200 copies per milliliter or synonymous with viral load suppression, that person not only stays healthy, but they cannot transmit HIV to sexual partners. This is a game changer for people with HIV and for the field itself. First and foremost, if you think about it, so many of us who live with HIV never imagined a time when we could love, we could have sex, we could conceive children without fear. Fear had been present in the most intimate moments of our lives, and U equals U sets us free. It transforms our social lives, our sexual lives, our reproductive lives. And U equals U dismantles the stigma that we've been living with and dying from for decades since the beginning of this disease. It changes the way that people with HIV see ourselves, the way others see us, the way we're treated in clinical settings, and the way policy decisions are made about us in housing, in education, employment, healthcare. And U equals U is aligned with our treatment goals because it's reducing people's anxiety associated with getting tested. And it's increasing people's motivation to start treatment and stay on treatment and stay engaged in care for their health, and also so they're not passing on HIV to their partners. And it's really important to understand that U equals U is a public health argument to increase access and remove barriers to treatment and care and diagnostics so that people living with HIV stay healthy and stop new transmissions, which is the cornerstone of ending the epidemic. And so I'm just want to revisit how U equals U is important to our treatment goals, because I think this is important, especially for providers to understand that there's now data from Positive Perspectives Waves 2, a recent research study showing that when providers inform people living with HIV about U equals U, they are more likely to report optimal treatment satisfaction and adherence and viral suppression. So we're seeing improved outcomes, quality of life outcomes and treatment outcomes when people are informed about U equals U, when patients with HIV are informed by their providers. And unfortunately, we're also still seeing about a third of the people in this study, and this was a study of 25 different countries, over 2,000 people with HIV about a third were still not being told about U equals U by their providers. So they're lagging behind. And now I also want to revisit the U equals U as a public health strategy. Why is this so important, not just to people with HIV for personal health outcomes, but for public health outcomes? How is this a public health strategy? And again, there's also data to back this up. So when we argue for increased access to treatment and testing and services, we have typically been arguing because this is important for the well-being of people with HIV. And that's really important. But now we also have data to show that that's not only important for the well-being of people living with HIV, but because this will reduce new transmissions, the more people with HIV who are on treatment and getting the care they need to get to undetectable, the fewer new transmissions there will be. And this will lead us to the end of the epidemic. And along with PrEP, U equals U is really the cornerstone of ending the epidemic. Or as Dr. Anthony Fauci said, U equals U is the foundation of being able to end the epidemic. So we know U equals U is so important for personal health, for public health. It's this transformative message, most important news we've heard since the beginning of antiretroviral therapy. Why did we need the U equals U campaign to get this message out? And why do we still need the U equals U campaign? Well, first, when you think about it, not a lot of people had access to this information. So there was a groundswell of studies since 1999, really, that contributed to proving what U equals U was. But a lot of folks didn't know about this study, or if they did know about the studies, they didn't have the expertise to draw a conclusion based on all that groundswell of evidence about U equals U. And then if they did draw a conclusion, well, maybe they didn't have the authority to come out and put that in writing and say it in public, or the character to be able to do that, to be the first to come out and say, this is true. It's a scary thing, even when you know it's true. And then also, this is something that we're still dealing with today, is these concerns about people with HIV not knowing that medication only works if you take it. So basically, these unsophisticated consumers are not smart enough to understand U equals U. Well, we have to stop blaming other people and take responsibility for ourselves as sexual health educators and healthcare providers, that it's up to us to explain it to them, not just assume they can't understand it. And then what we also hear is that this will give rise to additional condomless sex, and there's already a rise of STIs. Well, that's just kind of a separate issue. Whether or not someone can or cannot transmit HIV when they're virally suppressed is separate from whether there's a rise of other STIs. You don't hold one disease hostage for another. What you do is you educate about the truth of U equals U, and that U equals U, an undetectable viral load, doesn't prevent against the spread of other STIs or unintended pregnancy. There's still condoms for that, but you don't need to use a condom when someone who is undetectable is seeking to prevent from the spread of HIV. Undetectable prevents the spread of HIV, not other STIs. So under a lot of this kind of, making decisions about other people's sex lives or judging whether people have the ability to understand U equals U or not, was really a lot of this paternalism and prejudice and stigma against people living with HIV and the kind of people associated with HIV, whether this is based in racism or homophobia or transphobia. But a lot of these decisions were fueled by that and not by science. And that's not where we need to be. We need to follow the science. We need to follow the data. And then finally, it's really, a lot of it is about resistance to change. This is a radical challenge to the status quo. It's a radical change to what we've known about HIV and people living with HIV for years. And so people are just uncomfortable moving and making that change. And so what we had is this really important, radical message backed by science, but nobody was taking care of that message. The research was publicized independently by the institutions and the journals that fund and promote those studies. So there wasn't really this agreement on the groundswell of evidence, except with the Swiss statement in 2008. So we had to become the publicists. And our feeling behind this campaign was, everyone has a right to this information about our bodies. HIV stigma is a public health emergency, one of the greatest challenges to ending the epidemic, and we know U equals U is an immediate and effective public health solution. And we know disseminating U equals U is essential for personal and public health, but people need to know about it for it to have any kind of an impact. So our feeling was, we're going to tell the truth or we'll tell it for you. And so what we did was we went directly to the top scientists who were overseeing the studies, the groundswell studies that prove U equals U, as Dr. Roger told you also during this webinar. And we said to them, your science isn't getting out to the people who's intended to benefit. And so the idea was to work with the researchers and create a consensus statement and then a video with the voices of people living with HIV, and take that statement and the video and our voices and go out and change the narrative about our bodies. So our idea was to engage influential people and organizations to join us in confirming what we knew was true. And we were very lucky that very early on, the New York City Department of Health and Terrence Higgins Trust joined the campaign right when we issued the consensus statement in July 2016. And we started talking with the US federal health departments about updating the official risk, and particularly with the US CDC about updating the risk to align with the current science. At that time, something extraordinary happened. We didn't know that this campaign would go global, and all of a sudden it started blossoming all around the world, thanks to the power of social media and really the passion of people with HIV and the people who care about people with HIV. So as you can see on the screen, there are programs all the way from Kazakhstan to the Ukraine to Norway, Moldova, Zambia, Indonesia, and this is just a glimpse of some of the campaigns and the activity with activists and researchers and public health officials together getting this message out. So a lot of this activity was about a celebration, and so you can see protests in the streets of Kampala and Paris, at International AIDS Society, at the United States Conference on AIDS, and we're celebrating this incredible new information, this new lease on life that so many of us have. You can see there's high officials from National Institutes of Health, public officials, mayors, and activists all getting together to ensure this message gets out. And we were very lucky to have friends in high places. Dr. Anthony Fauci was a tremendous supporter of U equals U from the very beginning. This is him. He actually gives us these brilliant quotes every year. So the first was 2017, when he said the science really does verify and validate U equals U. 2018, when he said the risk is zero from a practical standpoint, the risk is zero. And then more recently, last year, that U equals U is the foundation of being able to end the epidemics. I'll tell you a little bit about what's happening in the United States with the Federal Health Department. So this has been a really productive relationship with the U.S. Federal Health Department. It's not necessarily the high up level of government, but the health departments. A year after our conversations began, they confirmed there was effectively no risk of sexual transmission. Effectively means in effect or actually, but not officially. So it means no risk. We're very confident with that phrase. Some people were confused by that phrase. When the CDC then came out and said U equals U is 100% effective at preventing sexual transmission, there's no ambiguity with 100%. 100% is 100%. And then because they knew folks were confused about what effectively no risk means, the CDC came out and authorized the messaging of U equals U. They sent a letter to the field basically saying that the U equals U can be used by CDC grantees and public health bodies. And then the U.S. integrated U equals U into their treatment guidelines last year, along with other and I actually want to just salute all my colleagues who are part of this whole discussion from the CDC, HHS, and NIH. I think we worked really well together to get to this place that really made history. And when the U.S. updated their treatment guidelines last year, it was a real milestone to have U equals U kind of officially into the guidelines. We were seeing that also in places like Brazil, Vietnam, Canada, Zambia, and England have also updated guidelines to include U equals U. So now every international agency has taken it on, accepted U equals U in one way or another. whether they're using the words U equals U or just confirming that the science is true. It's very exciting to see. So we're at a place where there's now over 1,000 partners from 102 countries, every continent, that have signed on and are promoting this message and really changing the very definition of what it means to live with HIV. So I'm going to show you a couple of campaigns and then give you some tips about how to be a part of this and how to communicate this message. In the UK, Terence Higgins Trust has, well, actually around the world, I think Terence Higgins Trust is the global epicenter for U equals U campaigns, all kinds of campaigns, whether it's social media or traditional media or outdoor advertising or provider trainings. They're doing really extraordinary work. Terence Higgins Trust, as well as National AIDS Trust, Saving Lives, and all the groups on the bottom like AIDS Map, British HIV Association. I could go on and on. There's so much activity in England, and HIV Scotland in Scotland too. Vietnam has the most comprehensive national campaign. It's called K equals K in Vietnam. This is funded by CDC, by PEPFAR, by the Vietnamese Health Ministry, and it's really groundbreaking and extraordinary. It's an example of how government and community work together to get this message out through multiple channels. Working with researchers, working with providers, working with the media, with journalists to ensure that people with HIV, providers, policymakers, and the public know U equals U. It's really tremendous example of a national campaign. And then I was really moved to see that there was a U equals U campaign in Venezuela, in the Guararo tribe, which is the oldest indigenous tribe in Venezuela, has a U equals U or M equals M campaign to reduce stigma and inspire hope. And this is a place where even at times basic necessities are out of reach, let alone HIV treatment, access to treatment. And also the fact that the China CDC has declared U equals U as well is very exciting, and the activists in China have been extraordinary. So, given all of this incredible energy around the world, where are we? Where are we with, how are different countries doing with getting the message out? And I think that's a real conversation to have here in Russia, and to see how are healthcare providers communicating this, if they are. I think that this is a really important quote from Edwina Wright, that it's a scientific and clinical imperative for healthcare workers to promote U equals U. And there's ways that you need to promote U equals U. It needs to, it's not just, you have to be mindful in the way we talk about it. It has to be clear. So you have to be absolutely accurate. There is no risk. It's not a reduced risk. It's absolutely no risk, because every tiny risk, a window of risk, puts a person with HIV's life at risk. There is no risk. There's no risk. When we're considered a risk, it really puts us at danger. And we're not. And confident. So you don't want to say, oh, I believe U equals U, but you never know, or use a condom just in case. No, U equals U is real. I'm confident in it. And if you want to use a condom to prevent other STIs or pregnancy, you might consider that. But U equals U. You got to be confident in your behavior and the language that you use, and consistent. It takes time for people to recognize it. Kind of have to communicate it over and over again, so people can integrate it into their way of thinking. And also conscious. We need to be sure that we're not shaming people who don't have undetectable viral loads. No one living with HIV is a danger. If you have a detectable viral load, there's still condoms. In some parts of the world, there's PrEP to prevent from passing on HIV or acquiring HIV. So provider consequences. So it's just unethical to tell someone that they're infectious when they're not infectious. It's just wrong. It's just that's evil. That's terrible. There's no question about it. And there's no medical justification for doing that. And what's happening, we're seeing to doctors, is that we're seeing that patients are finding out about U equals U elsewhere, and it's breaking trust with their doctors. In some places where they have the luxury, they're firing their doctors and they're going elsewhere. But at the very least, it's breaking trust, because we're going to learn. People with HIV are finding this out. And if you're not sharing this, it's just wasting opportunities to improve your patient's health and public health. So one thing I talk about in terms of, there's a lot of fear and anxiety still about this, because change is hard. And it's important for us to recognize what cognitive dissonance is, that we are motivated to reduce that discomfort between old ways of thinking and new ways of thinking. And we'll look at facts that confirm old ways of thinking in order to reduce that comfort. So we have to really understand that. We need to recognize that, you know, these are feelings and they're facts, and we need to move with the facts. We need to separate feelings from facts, consider the impacts of not sharing this information, and consider the positive impact of sharing this information. And then I also say to borrow confidence from the expert. If you're not an expert in HIV transmission risk, then borrow confidence from people who are experts in the field in that area. And that's our jobs really, is if we're not an expert, we seek out advice from the experts, and then borrow strength from the voices of people living with HIV. And I'm just going to close with some of the voices of people living with HIV and a very important person to the field. You know, what I hear over and over again from different countries is that it makes me feel normal. I don't feel like I'm a threat in any way, people are saying. And Donna from New York, this broke my heart. She said that U=U had given her womanhood back that was stolen by the disease. You know, and she has a new desire to love. And I really related to Daniel talking about how when he used to see there was a small risk, that's still a heavy load. When you're a greatly reduced risk, that's a risk. But when you're no risk, you feel empowered. When there's no chance, that's freedom. That's freedom. And Catherine, Catherine from Zambia talks about how she no longer sees herself as a danger. And we hear that a lot. I no longer see myself as a danger. I no longer see myself as a threat. I'm normal. I feel normal. And now to providers, I'd like to bring in my friend and dear colleague, Dr. Allison Roger. This was our conversation at the World AIDS Conference, which was a 2018 pivotal moment in my career and in the campaign.
We've got one more, and it has to come from U=U himself.
Hi, Allison. Today is marking a revolution in what it means to live with HIV. So thank you so much for your research. I have a question on behalf of the U=U campaign. There are many providers that are still not accepting this message. They try to focus on the risk is not zero scientifically, or they focus on their patients aren't going to be adherent and they won't know that they're detectable, or they say there's a rise of STIs already, so they don't want to share this with their patients. We get every single kind of excuse. What would you say to clinicians or any other information provider who is withholding this information from people with HIV?
Yeah, and I just want to pay tribute to the U=U campaign. It's been astonishing. I think the time for excuses are over. I think it's very, very clear that the risk is zero. So I very much think we have to promote this. I think if you're on suppressive ART, you're sexually non-infectious, and yeah, the time for excuses is over. And I again pay tribute to you and your work. Thank you.
Well said. Thank you, Alison. Great.
So I hope that everyone who is watching this webinar has the opportunity to share this information with someone with HIV who doesn't yet know about it. It's really transformative. It is so moving, and it's so important, and it really is changing the world for people living with HIV and the people who love us. So thank you so much for signing on, for paying attention. And here's my contact information. Our organization's Twitter account and Facebook group are very active, and feel free to be in contact with me if you have questions or need more information about the campaign. Thanks very much, and thank you so much to everyone at PROHIV and for inviting me here.
Thank you very much, Bruce, for a very inspiring presentation from the position of person who lives with HIV and tells the story of yourself or other people, where the concept U=U changes life, transforming life transforming message. And now I would like to ask a question to Natalia Ladne. because we have a feeling that Russian doctors yet do not trust completely this concept. There is some, reserved position that Russia normally has its own way, our own scientific data. What is your personal position? And what do you think, how, accepted this approval of U equal U in Russia? Thank you very much. Well, I actually adore presentation of our wonderful speakers. I think it was impossible to find better personalities for this topic. So we really have wonderful representatives today. So one of them showed very convincing scientific data, and I totally support this concept. And that is why I'm a part of this roundtable, because I believe that when we get such reliable data in such large, comprehensive international trials, it will be very difficult and simply impossible to ignore this information. Why I'm supporting this concept, EU is equal U? I think it's extremely important for the reduction of stigmatization and discrimination, for the improvement of the quality of life of people living with HIV. I think this is a principally important thing that forces us to talk about the concept, to promote this concept. And if we again say to what extent this concept is supported or not supported in our country, in fact, we see that there is not big difference with other countries. I don't think there is big difference. So very recently, we carried out survey just right during our presentations, and if you can appreciate, well, I hope you saw the results of the survey. It appeared to be that among the attendees of the survey, 64% they trust this concept, and among the patients who passed through this survey, also 74% they trust this concept. But as far as I knew that I'm a part of this roundtable, of this session, then I asked my colleagues, my friends, my acquaintances about this concept U is equal U. And mainly I focused on the skeptically oriented people. I asked, and what is your doubt? What is your fear? Just tell me. And from the colleagues, I heard that mainly their doubts are that they carry personal responsibility for those medical recommendations they can give to their patients. And it appeared to be that when they provide such recommendations to the patients, but they simply couldn't do it, they didn't. So they're thinking not about the transmission of HIV. Normally they understand if the viral load is undetectable, then there cannot be any transmission. But it appeared to be that what they're concerned by is transmission of STDs. Some colleagues were telling that, in fact, not so many people yet do have fully suppressed viral load among those who are getting ART, and they're simply concerned that those people who start treatment, they can automatically imagine that they are not transmittable anymore. But in fact, for example, last year, we had increased share of those patients who are on treatment and who have undetectable viral load, but still it's, 400,000 people. But to our estimation of the Federal AIDS Center, we have about 1,400,000 those who live with HIV. So still, the share of patients with suppressed viral load is not so high. This is why they are concerned by that. They're also concerned by the fact that still there were very many people who stop treatment, discontinue the treatment, interrupt, because last year in 2019, we know that 7% of those who were getting treatment simply terminated it. And in this context, we understand that definitely the risk of increasing viral load is essential. It's there, it's very real. And I think in this context, my colleagues also were telling me that actually we don't test them so frequently. So to what extent can we be sure that the person was not non-compliant, that he was quite compliant and taking all the drugs is probably if we test them pretty rarely, sporadically. So yes, these are the concerns they have, and actually they are the barriers for their open communication with the patient about the concept of U is equal U, which is undetectable, means untransmissible. And I'm thinking about it. What else can be done? What else can we do? Because really, the propaganda of these concepts could be very useful to increase trust to the doctors, to increase the quality of life of people living with HIV, and also to reduce stigma and discrimination, because stigma and discrimination, that's very serious challenge, and I think it's still very significant in our country. But we need to understand that we need to design real pathways. In the Federal Center, we understand, yes, this concept is working, but somehow we should give instructions, guides, but whether these guidelines implemented or not in the real life. So actually mechanism is not quite clear to me. How we have to provide this concept to be widely used. And finally, at the same time, we need to understand that this concept should not replace or substitute simply use a condom. Because some of my colleagues, they immediately asked me, but why do you need this concept? U is equal U. What for? To avoid condoms. So probably just for that. And very frequently, specialists, when they talk about it, they say, oh, probably there should be some legal consequences to that from this concept. Probably. Because it's not a secret that in many countries of the world, including Russian Federation, there is criminal liability if you infect someone with HIV. But just legal consequences, can we think about them, let's say, in the frame of this concept, and how it can be proved? So how can you be sure that yesterday or today, let's say, when he or she is having sex, that his or her viral load is really undetectable? So in fact, here it's, first of all, high quality of treatments, then high quality of medical care to the patients, and we're really eager to that, to have it. And here we mainly speak about effective antiretroviral treatment, long-term effective antiretroviral treatment. And when more and more people will have this suppressed viral load, then I hope this concept would be quite prevalent and would also be welcomed in our country, like in many other examples presented by our brilliant speakers before. And I do hope that more and more HCPs also would stick to this concept and provide this information to their patients. Thank you. Well, thank you very much. Your words are very important. Well, definitely. We are supporting the concept, and no stipulations, no limitations. We fully support it. And I'm happy to give the floor to Alexander to speak up, to provide his position. And then we will ask our international guests to join us. So Bruce, well, 6 a.m. New York, early morning. Good morning, Bruce. But now Alexander is speaking. Yes, happy guys. Great to see you. Thank you for waking up so early for this important event for us. Well, I'm really deeply impressed. Deeply impressed by these two presentations, Bruce and Alison. And well, surely I belong myself as an advocate to advocates, and I'm fully supporting the concept. That's why we organized this separate session just dedicated to this concept in order to make it rooted in Russia as fast as possible, to have roots. And in order to do it, we need to speak more about it, more and more. Natalia tackled important objections, frequent objections. Yes, definitely. Part of HCPs, due to these or those reasons, sometimes they have doubts. Probably majority do know about the concept, maybe some of them don't, but due to some reasons, they are not broadcasting this concept openly to the patients. They are not talking about it. And we saw that Russian surveys don't show different data from surveys of different countries. One of the reasons is that in Russia, and until now in some specific regions, this is mainly epidemia among intravenous psychotropic drugs. But here we're speaking about sex transmission. That is why doctors maybe separate these two phenomena. They don't see, let's say, big need to tell these psychotropic drug users about that. So they're dealing with this very vulnerable group, and here are approaches that could be different. On the other hand, as it seems to me, and well, I agree with Natalia, because now we speak about Russia, and we want to absorb this experience, positive experience of other countries, to absorb it, to digest this experience in order to understand how to develop this concept here in Russia. I think here there are two contradicting vectors. On the one hand, you mentioned that sometimes there are not enough regular checkups, so they're tested not so frequently as they should be or could be. And this is true. We have to admit it. This is true. When you have no idea what is your viral load, or if you measured it last time a year ago, 6 months ago, what sort of U equal U concept you can talk about. I totally agree with that. But if HCPs, healthcare providers, professionals, will be convinced, if they are convinced, and this is exactly what we have to do, Natalia, me and you, we have to convince them, then probably one day comes when they have an understanding. That's first, and well, let's say not only one, but important task is the coverage of treatment, coverage by treatment. Well, in any case, it influences the pandemia rate, but the point of treatment is in its quality, in suppression. That is why we need this treatment, to suppress. And when these interests and when these concepts merge or meet one day, then we can celebrate the success, I believe. Also, I would like to add, the concept is extremely important, mainly for the community of people living with HIV. And as I heard from Bruce's presentation, definitely it increases your self-esteem, removes stigma, internal stigma, inside the community. Surely speakers of very high level, as you showed today, those who speak up on the issue, they generally strongly influence the public opinion. But unfortunately, as far as we know, the big public community not quite interested in the problems of HIV infection when it's not related to them. So we need to think about it, to think how in the general population it can also be an interesting topic. Well, dear colleagues, Bruce, Allison, so what do you think? What are the barriers and challenges in your countries when doctors, HCPs do not speak openly, do not support openly, or try to avoid discussing a U equal U concept? Please speak up, one of you.
Thanks. Sorry, Bruce, do you want to go first or will I?
Oh, you could go first if you'd like. It's so nice to see you.
It's lovely to see you too. So I think as Bruce showed in his presentation, the Terence Higgin Trust have very much led it in the UK as well as HIV Scotland. So it's just talking about it. I mean, I really hoped, I think, 2018 was quite pivotal. We had the Evidence U equals U astonishing campaign, and I kind of hoped that it would become more mainstream, and it is, but I think I will be talking about this forever, because I think you have to keep talking about it, you have to keep reassuring people, you have to keep giving people the confidence, as Bruce said, But, you know, as scientists, it's very unusual. Science can't prove a negative. So for us to actually say the risk is zero, it's a big deal. The evidence is so robust. So I think we just keep talking about it, giving people confidence. And it's not our information to hold on to as scientists. You know, we've provided the data and it's up to people. I don't think it's trying to encourage doctors and healthcare providers not to filter it through their experience. You provide the information. If you're suppressed on treatment, you're non-infectious, that's it. You know, none of the caveats, none of the sort of when do you last get your viral load. If you take treatment, you're adherent and you're suppressed, you're not infectious. So I think it's just keeping the clarity of the message and the confidence, as Bruce said. Thank you.
Yeah, absolutely. I would say the clarity, confidence is so important, and for advocates who are trying to move healthcare providers or other healthcare providers who are trying to move healthcare providers to agree, and not just agree with the science, but also want to communicate this. It's important to show that communicating U equals U is aligned with our treatment goals. It's aligned with doctors' goals to get people healthy and get people with HIV to be adherent and to be virally suppressed. That if doctors are informing their patients with HIV about U equals U, the data it shows that patients are more likely to be satisfied with their treatment and more likely to be adherent and more likely to be to stay healthier. So that's an important goal that we hope that healthcare providers share, as well as that personal health goal, as well as the public health goal that there will be fewer new infections if people with HIV are virally suppressed. So there's so many reasons. It's just going to take it's going to take time because it's so new, it's so radical. Even though it's a fact, you know, it's still a very, very new radical fact.
And I think just one more thing. So I've got quite interested in mental health of people living with HIV and stigma. And you often see the levels are, you know, almost double the general population. I think a lot of that is stigma. And I think U equals U just takes that away. I mean, if you regard yourself as you're not infectious, that's a massive step. And I think it's something we really need to look at in terms of health and well-being of people living with HIV in a kind of complete way, improving people's mental health. And I think U equals U is really important for that.
Thank you very much for your comment. Wonderful words. I would like to go back to what Natalia said about the use of condoms and this position of particular HCPs. So they believe simply that if you tell them openly about the concept U equals U, they stop using condoms, and then we will have flare of STDs or whatever, or unplanned pregnancies. Alison, your comments, please.
I think, again, Bruce put it beautifully. I mean, it's not... You can't sort of prejudice one disease because of what may happen to other infections. So I think this is very much about HIV, and I think the implications of U equals U are massive for all the areas that we've discussed, and it's not our right to withhold this information. Whether people choose to use condoms for other reasons, such as STIs or pregnancies, that's up to them. But all we're doing is trying to give people the information. And for HIV, it's really clear. You don't need to use a condom to prevent HIV transmission. If you have sex with other people, and we saw that in the partner studies, 15 negative men became positive because they had sex with other people. So there's obviously a role for condoms, a role for PrEP, if you have sex with other partners and you don't know if they're on suppressive ART. But for HIV, if your partner's suppressed, you do not need to use a condom to prevent HIV transmission. It's so clear. I don't know, Bruce, if you've got anything to add to that.
That was perfect. Beautiful.
Okay, thank you.
All right, then. We go back to the issues of implementing the standards or the concepts in the big masses, because I know the example of Australian organization, clinicians in HIV infection, and they made a special guideline for HCPs. They created a guideline how to consult the patients about the U is equal U concept, what to say, which wording to use, why is it important, and how you need to explain that. Do you think maybe it's worth designing similar type of guidelines in every country? And do you see such special guidelines for HCPs in UK and then in US? And then the question to Natalia later, whether we need to design these guidelines in Russia as well. Thank you.
Absolutely. These kinds of guidelines are essential. They're so important because you know, again, U equals U is new information. It's very basic. It is very simple. If you're on suppressive ART, you're not infectious. But it's a scary thing to say. It's new, and people are resisting saying it because it's new. And so people need to be guided, and they need to be guided by credible institutions and those sort of at the top. So what we're seeing in places like Australia, like Vietnam, like the United States, for instance, we have guidelines that are are encouraging, or doctors are sharing with healthcare providers that this is an imperative to say U equals U, and this is it's an accepted fact, and this is accepted in the medical and scientific community, and you need to say it, and so the guidelines are really important. There are guidelines also from British HIV Association in the UK, and there may be some others that Alison can share in the UK, but this is really important. We have great examples of guidelines on our website, and we would encourage in all across the globe for healthcare institutions, federal health ministries, research associations to work together to create guidelines for their populations.
Yeah, I would agree. And a lot of the community organisations in the UK have been really active, like AIDSmap and iBase, working with Terence Higgins Trust, who actually have, so the community have been so active in summarising the evidence in an accessible way, and also developing guidelines for healthcare providers to use and for people living with HIV and their partners to read. So I think the community have been really important in driving this.
Thank you very much for your comments. Well, I believe it's definitely not enough that we put some article on our websites, because in many other publications, documents, we already wrote before that the people with suppressed viral load cannot sexually transmit this infection. It's already written in our documents, many documents. But in order to dispel these fears, concerns, doctors not to be afraid to talk about it, to tell patients, I think for that, we need to design guidelines, maybe clinical guidelines, maybe we should mention that, and we need to, have very accurate wording there, because it is not just enough to say, oh, it's equal. It's very simple. U is equal U. You are not risky anymore, so you can go home. Goodbye. Have a good life. No, that's not the story. We have to speak about the risks of about unplanned pregnancies or STDs. And again, in what context, how we have to provide it, with which dressing, I would say. But we need to understand that the patient, the person should get reliable information, truthful information in the appropriate volume, which is available. That is why possibly if we have such guidelines, but well, we need to think about it. Well, I haven't yet seen such desire from our community, maybe in the consultation session, or maybe in the section on the improving compliance of the guidelines, different segments of compliance, because definitely I believe it can improve dramatically the compliance, because for people living with HIV, that would be very pleased to know, to get this information at last from the first hands, from your treating doctor, not somewhere whispering in the corner or half officially, but very officially, loudly. If they speak loud about that, I'm pretty sure that there is increased trust between the patient and the doctor at the end. But at the same time, we need to understand doctors' fears and concerns and fears of practitioners, because they work with patients for years, for decades. They manage these patients, so they continuously come to the same doctor. And if today doctor is saying is U is equal U, you are not risky anymore, and for example, at the next visit, he would identify STD, then he starts thinking, was I right saying that last time? Maybe I did something wrong, because now it's STD. Maybe I was wrong from the very beginning, and maybe it's not worth being so open and frank with them. That's why we need to find a good balance in between these two positions. So on the one hand, it should be a position of patient support, providing truthful, reliable information to the patient. But at the same time, we need to understand that actually it's personal responsibility of the doctor. what happens to the patient next? And this is very serious responsibility. That is why we need to provide particular references or maybe links to important documents, trial results or other references that can be useful. And I think only this way we will be able to promote this concept seriously, because while we are just talking, that's wonderful, that's magnificent, you made such fantastic presentations. So you are inspirational speakers, you are motivational speakers, Bruce and Allison, you should come to Russian Ministry of Health and they will have no doubts in the concept. But at the same time, you need to understand these legal aspects and particular aspects of inertia. Yes, legal aspects. We need to think about it as well. Thank you. Well, all right. So for us, task now is to design these guidelines, and we'll take this task on board and we will speak about it later. And now Alexander wants to comment. Well, I totally agree. That's absolutely right. Natalia tackled a very sensitive issue, that there are some legal consequences of that. And I don't know whether there were cases in UK or in the United States, let's say illegal cases, when the patient either getting unscheduled pregnancy or being infected by STD could sue the doctor or the clinic or somehow declare their rights, providing complaints saying that, oh, that's what you who told me 6 months ago that I'm totally free now, and I interpreted it that exactly that way, and now it's your fault. Any cases like that?
No, because I think we're really clear to separate it. So U equals U, and the message of U equals U is you're on treatment, you're suppressed, you will not transmit HIV. But if you are worried about STIs or you're worried about pregnancies, then you should use a condom. So it's completely separating it. And I make that very clear to people. The whole message is making that very clear. We are just talking about HIV. But it's such a powerful, massive message that it's really important to talk to people about it. You're giving people the information in as clear a way as possible. If you're suppressed, you cannot transmit HIV. You are still at risk of STIs. You're still at risk of HIV if your partner is not on treatment or suppressed, so you don't know the status, but it's completely separating that message. And I think we need to keep saying that this is the separation of messages. I don't know, Bruce, if you've got thoughts.
Absolutely. Well, very well said. Very well said. I mean, I guess I should just say that I think the fear, people need to get over that fear of that just generalized anxiety about what if. No, this is a fact that if someone is virally suppressed, if someone is undetectable, they cannot transmit HIV sexually. That is actually really true. And a lot of this anxiety about STIs or anything, that all is just, that's part of cognitive dissonance, I think. I think people are looking for new data to confirm their pre-existing ways of thinking, because it's so uncomfortable to be in that place of here's new data and here's old data, and that change is really hard. And so there are all kinds of excuses, but as Allison said at the World AIDS Conference back in 2018, and always says the time for excuses, it's very, very clear that the risk is zero, and these other issues are separate. We need to talk about STIs, but that is separate from the fact whether someone who is virally suppressed can or cannot transmit HIV.
So, yeah, I agree. I think it's part of the conversation that you have with people. The good news that you're virally suppressed, you're sexually non-infectious in terms of AIDS.
Well, I think you should not convince us. Definitely, we need to understand that we have to separate the concepts of pregnancies, STDs, and concept. it was just, innocent question. I just wanted to know what's the situation in your countries. I'm very innocent. I didn't want to provoke you. If you tell me about that, I would understand that. But, unfortunately, people are very different. People are very different. And I simply ask a question, very simple question, Thank you very much for sharing. I didn't want to sound like a provocation. So I wanted to show that I'm completely convinced. It's deep in my heart. Yes. Alison, please,
it's
we
not
interrupted you.
It's not a provocation. No. I was just saying it's not a provocation. It's good that you're raising these issues because these are the questions that we get all the time, and it's really important to give a response to these so that we talk about absolutely everything to do with equals U, so people leave the session feeling really confident.
Yeah, and sorry, I'm an activist, so sometimes I respond in a way I'm an angry activist. But that was a great question. It was a really important question.
Our conference is famous as we have so many activists among us. So among activists, we have doctors who are asking questions in chat. He is writing, I have concern about pregnant with U equal U. Do we have enough data on pregnant in the light of this concept? Thank you. What can you say? Pregnant, group of pregnant.
So
question is to everyone. Yes, please. Who wants to speak up? Because I believe that in pregnant we have full set of data. I believe we have full set of data. Alison, can you add on something on pregnant?
I'm sorry. Is it the risk of a pregnant woman becoming HIV positive? Is that the concern? I don't think there's any. U equals U applies. I mean, if you're suppressed, you're sexually non-infectious, pregnancy makes no difference at all.
So this question in the chat, I just translated it as it is. So probably the risk of infection during pregnancy or during the conception, I believe, maybe that was they mean. So because this is question from chat,
yeah,
we cannot ask the doctor.
I think that's a really important point. That now, as Bruce said, you're free to have children. U equals U applies. If you're suppressed, you're sexually non-infectious, you can have a baby, you can have sex, and the fact that you want to get pregnant or you are pregnant does not impact on the U equals U statement. Again, it goes back to you may want to use condoms if you want to prevent a pregnancy or you want to prevent STIs during pregnancy, but in terms of HIV, if you're suppressed, you can't transmit, and pregnancy is neither here nor there, really. That would be my answer anyway. I don't know if anyone else has any other comments.
Well, I think this is very complete answer. This principle, U is equal U, is also applicable to pregnancy. About lactating, that's another story, but we're speaking about the sexual transmission. So U is equal U is a principle that is working for the sexual transmission. So what else can I add on from myself? Very frequently, a patient's asking, why? Why do we need to start treatment? And for many of them, this concept U is equal U can be a motivating factor for the beginning of treatment because the doctor cannot find arguments, cannot put dot over the I that you need treatment here and now because people feel good. They don't have symptoms, no pain, and they believe, what's wrong with me? Come on, maybe we should start treatment later. Yes, we know about the START study, we know about the early start of treatment, but still, these are words. This is theory, but when we can tell him or her that in the near future, right after you start the treatment and your viral load becomes undetectable, you will not be able to transmit to your partner. That's additional, very strong motivating factor. And especially we see it in MSM group that really are quite concerned about that, very frequently concerned. And I think that's very important to remind them more frequently and better way. Alexander, any comments, questions, remarks from your side? Well, we see many questions in chat now. They say, let's change protocols of treatment. Let's increase the pool of those who are tested. I mean, for viral load, let's do it once in 3 months, but not once a year, right? Like now, because Russian protocols, it's once a year. But I have to tell you, once a year, like now, they do it very rarely. The protocols are very different from the reality. Protocols are still different from the reality. So we can clarify from Alison. Alison, tell us, in the UK, how frequently patients who are undetectable come for the secondary tests?
Between 6 to 12 months. Once someone is suppressed and on treatment and there's no issues, then they can get 6 monthly to annual viral load tests. And that's what we did in the partner study. I don't think you need to measure every 3 months. I mean, the concept of U equals U is very simple. If you're on treatment, you suppress and you're adherent, then you'll stay suppressed. So we just monitor every 6 to 12 months now. I think it's probably the same in the US, is it, Bruce?
Yeah, it is. Mm-hmm.
The same with us. The same with us. So the standard of treatment is very similar. Another question: if person is undetectable and he's not disclosing the status, and how later on he could prove in court that there was no risk of infection, because we know in many countries there are laws, there is criminal liability. Because it's a risk of infectioning. I know such laws exist not only in Russia, for example, in Canada as well. So if person still undetectable, but according to law, can be accused because of potential risk for the partner. Bruce Ellison, what situation in your countries? What's about Anglo-Saxon law?
It's such a yeah. Sorry, Bruce, on you go.
Well, I was just going to say, yeah, it is very complex. Just briefly, this could be a conference in itself, and has been criminalization of HIV. There are still about 35 states in the United States that criminalize HIV. So whether it's non-disclosure or it enhances the sentencings of other laws like sexual assault from someone with HIV, and being undetectable is a part of the criminalization toolbox. So it's a part of this strategy. U equals U is part of this strategy to modernize these laws so that people who have undetectable viral loads have no risk of passing the virus on. So there's no risk of harm. And so in some places, like in Canada and other places around, in certain states in the United States, having an undetectable viral load means that you're not subject to these disclosure laws because you're not putting anyone at risk. But that's also really a strategy that will further divide people who have undetectable viral loads and who don't have undetectable viral loads. So it could create this two class of people with HIV: those who are struggling to get to undetectable, may not have the resources or access to treatment, and they're subject to the laws, where others are not subject to the laws. So it's really complicated. The laws should be based on, did someone intend to transmit HIV? Was there actual transmission of HIV? Not on simply someone's viral load status. Does that make sense, Alison? I'm sure you could add to that a lot more.
No, I completely agree. I mean, it's a hugely complex area, but gradually, I mean, there was the GIS statement in 2018, which basically reviewed all the evidence in criminal law, and gradually, globally, criminal law is being modernized to take account of the U equals U statement. I do agree with Bruce about dividing people living with HIV on viral load status, and I think the problem with criminalization is it just combats the efforts of the epidemic. I think HIV criminalization laws are completely abhorrent, and they're not based on the basic principles of law, as Bruce said, in terms of intent. So I think someone who's suppressed is protecting their partners in the best way possible. It's zero risk to their partners. It's obviously good in terms of a sexual relationship to disclose your sexual health status, but people don't have to, because you are protecting your partner in the best way possible, the very best way possible, by being suppressed. So yeah, I think it's a hugely complex area, and can't really do it justice in a couple of minutes we've got here. But I know it is an issue, and I know it's a concern for a lot of people.
Natalia. Yes, you are right. Topic is very complicated, because now the interpretation in Russia is very clear. The responsibility of person living with HIV, they have to disclose. They have to disclose. So there is no other interpretation. They cannot protect themselves if there is a claim or if there is a criminal suit. So if this person informed his or her partner, then based upon this information, in particular knowledge, there is independent decision of whether to have sexual contact or not to have sexual contact. And my understanding that in the current version, in the current situation, the person can say, I am not dangerous, I cannot transmit HIV infection, but still we believe that the status should be disclosed, We regularly face these challenges because we continuously get this information from people living with HIV. For example, they need adoption of children, and we write them conclusions. We write conclusions, and they go to court with these papers. They say that this is a person with HIV on a stable treatment, a suppressed viral load, not different from any other people. So multiple letters going to courts because these people, they want to adopt children sometimes, and the courts will never allow them without this confirmation. But even in this case, we can face some legal collisions because you need to prove it. You are undetectable, but probably in a very short period, versus sexual contacts that we're having. And if we test person once a year, so what sort of tests on the viral load can we get as approval? So in fact, it may mean how, let's say, how mastery are the legal people from both sides, how mastery they are. So I believe it will be very difficult to provide protection for people living with HIV in this concept. Yet no. I think many things should be done and a lot of work to do. So let's start from the guidelines. That's a very simple and first step, clear guidelines for the HCPs, how to provide consultation, how to speak up, what wording to use about the effective antiretroviral treatment and the concept U is equal U. Well, that's great. Thank you very much for your comment. That's really fascinating that all together we managed to get together to discuss this issue. So I hope after this session, we dispelled all the illusion. We're absolutely sure in the complete efficacy and confidentiality in the concept of U is equal U, and I hope that our doctors working in HIV centers will consult their patients mentioning this important aspect. And also in Russia, we will also show the same march like Bruce showed in different countries, having parade that U is equal U, it works, and we are ready to support it in all possible aspects, organizational and activist-based. So thank you very much for being with us. So it was great pleasure and honor, and especially it's a pleasure and honor to see our international guests who found time in their busy schedules to be with us. So thank you very much for this brilliant session. Hope seeing you again. Have a good day. Goodbye.
Thank you. Bye. Thank you. Bye.